We are going to talk about epilepsy, and seizure is the core feature or the core clinical manifestation of epilepsy. It has to be both recurrent and unprovoked. It could be any clinical manifestation, and it has to arise from the cerebral cortex. Our brain is always at equibalence between excitatory powers and inhibitory powers served by ions as well as neurotransmitters. In case of epilepsy, we do have a hyperexcitability, which is either due to excess in the excitatory power or less inhibitory power. This is in case of epilepsy. The International League Against Epilepsy has defined acute symptomatic seizures, which is the main differential diagnosis of epileptic seizure. As you see here, the interval between the insult causing the seizure and the seizure itself is less than a week. These are the etiologies, which could be in the brain itself or in the blood. Epileptogenesis is the process which turns normal cortical neurons into hyperexcitable ones. Here, epileptogenesis as a duration, it has to be more than a week to differentiate between symptomatic epilepsy and acute symptomatic seizure. The International League Against Epilepsy also come with a practical definition for epilepsy. As I told before, we should have at least 2 unprovoked seizures occurring in more than 24 hours apart. So 2 seizures in the same day is considered 1 seizure. Why we choose 2? Because statistics have showed that the incidence of the 3rd seizure after the 2nd seizure is more than 50% in the next 10 years. We also can diagnose epilepsy if we do have epilepsy syndrome. We will discuss that later. The prevalence of seizure is nearly 80 per 100,000. As we can see, this number drops in case of epileptic seizure to 45 per 100,000 seizure. That's why we don't treat patients after having single unprovoked seizure. There is particular situation where we can start treatment of epilepsy after the first unprovoked seizure, where the prevalence of the 2nd seizure after this first unprovoked seizure is more than 50%, a point which is similar to the prevalence of the 3rd seizure after the 2nd seizure. These are the situations if we do have a prior brain insult, an abnormal EEG that is known to be associated with recurrent seizures, abnormal MRI or CT brain, or the first unprovoked seizure occur while the person is asleep. These are the different symptoms that is common in patients with epilepsy. Some of them you will find them motor, some of them you will find them non-motor manifestations. All of them are served by different brain functions. You might hear automatisms, which is an abnormal automatic behavior. Could be emotions, sadness, laughing, tonic seizures, clonic seizures, atonic seizure, which is loss of muscle tone as a whole, behavioral arrest, which is sometimes called freezing, and hyperkinetic seizures, which is very characteristic for the frontal lobe seizures. That's why we should have an epilepsy classification based on this symptomatology for doctors to speak with each other and to explain for their patients. For this classification, we do have very important points that helps us classifying these seizures, like the seizure onset. Is it focal, arising from single area of the brain, or generalized, where both cerebral hemispheres are affected at the same time? The awareness of the person having a seizure, is he aware of the time, the duration, the people surrounding him during the event, or he is not aware? Is the awareness impaired from the start, or would it happen later on? Is the clinical manifestation motor or non-motor, as we described before? So this is the new International League Against Epilepsy classification in 2017. We divided epilepsy into focal onset and generalized onset, and if the seizure was unwitnessed, we put it under unknown onset. The focal onset seizure, we differentiate between is it aware seizure or with impaired awareness. So if the person can describe all the event, it's aware seizure. If he cannot describe the whole event, it's called with impaired awareness. This is further classified or subclassified into with motor manifestation or non-motor manifestation. While the generalized onset seizure would be classified directly into motor and non-motor, as all generalized onset seizures are associated with impaired awareness. This is a more longitudinal classification where the motor onset seizure was subserved by these symptoms: automatisms, atonic, clonic, spasms, hyperkinetic, myoclonic, tonic. While non-motor seizure in the focal onset is different from the non-motor seizure in the generalized onset. The non-motor onset with focal onset could be autonomic, behavioral arrest, cognitive, emotional, sensory, while the non-motor generalized onset seizure, either typical or atypical, typical, which is the famous PT-MAD epilepsy, or the atypical, which is sometimes associated with some motor manifestation like eyelid myoclonia or nocturnal or urine incontinence. While the unknown onset seizures are also subclassified into motor and non-motor epilepsy. This figure on the left shows you a focal onset seizure. When we describe it, we would say a focal seizure. This seizure is tonic, so we would say focal motor tonic seizure. While on the right side, we do have a generalized onset seizure, and it's also motor in character, and this motor in the form of tonic spasms of the forelimbs. So we'll say a generalized motor tonic seizure. Impaired awareness or impaired consciousness during a seizure is very important because it might be responsible for a lot of injuries, like accidents while driving, like some jobs that needs full awareness of the person, or even during school time, where people who do have absence or impaired consciousness, it will interfere with their scholastic achievements. This slide shows the old terms versus the new terms as regard the old and the new classification of epilepsy. I will describe here the most common form of epilepsy, which is the generalized motor tonic clonic seizure, where the person falls down suddenly with a cry due to the force of air through tonic spasms of the vocal cords. He will fall down because of the tonic spasm of his lower limbs. When you look at his face, you will find his eyes elevated upward because of the tonic spasms of extraocular muscles. We will see him clenching his teeth, might be biting his tongue, and his mandible is closed. This will lead to decrease of air entry across his larynx, so you might see his face turning blue, associated with these tonic motor events of his upper limbs and lower limbs, where the agonist and antagonist muscles are working simultaneously. After a minute or two, it is followed by what's called colonic contractions, where the agonist and antagonist muscles will reciprocally contract. This is associated with frothy discharge from the mouth. It remains also for 1 or 2 minutes, then it ends in a post-ictal state where the person stay with impaired awareness for a while, sometimes with psychiatric changes like psychosis or pain, and the head would be headache or muscle aches. He might be sleepy, and he might go to sleep for a few hours until he gets his energy back again. This is the most common generalized seizure. While the most common focal seizure, we do have focal aware, where the person will come and describe what he really feels. The temporal lobe is the most common one, where the person might complain of a rising abdominal sensation, sometimes associated with autonomic manifestations like sweating or flushing. The focal motor Jacksonian seizure arises from the motor strip, and it goes through a Jacksonian pattern where if it starts from the angle of the mouth, it will take the right upper limb, sorry, the contralateral upper limb, then the contralateral lower limb. If it starts in the lower limbs, then it will take the face and the upper limb. This is the Jacksonian march course, usually followed by what's called Todd's paralysis, where the person will have temporary weakness of one side of the body, which was ceasing for less than a week before it comes back again to normal. While the focal unaware seizure, which is one of the most intractable seizures to medications, usually arise from the temporal or the frontal lobe. The temporal one is more resistant to treatment. It is usually, as you see, starts with a rising sensation from the abdomen, followed by behavioral arrest. So the person will have that funny look on his face. Then afterward, there will be some automatisms where there is recurrence of simple or complex motor acts, sometimes in the form of a swallowing movement or chewing movement. It may take any kind of complex or simple movements. Afterward, the patient will become aware again, but he will totally forget about what was really happening. So it's amnesia. Sometimes it's called the 4A's aura, which is the first presentation of the seizure, then the absence, the second A, then where he is unaware of what's happening, then the automatisms, this is the third one, and lastly would be the amnesia for the event. The aura will differ according which lobe is affected, is the frontal, temporal, parietal, occipital, and which area of the brain is really affected would be the symptoms referable to it. Thank you. In this part, we are going to speak about management of a seizure. These are the questions that each one of us needs to think about when we face a patient having a seizure. The first one, is it a seizure or not? The second one, is it provoked or unprovoked? Then we speak about the type of seizure, and then we proceed to the examination if there is interictal CNS dysfunction. What are the kind of investigation that we are going to perform? Then Is treatment justified, and which drug should we start with? First one, is it seizure or not? Simply speaking, we do have what's called seizure mimickers. These are events that looks like a seizure, but they are not seizures. Come on top of the list: syncope, whether cardiac syncope secondary to arrhythmias, or cerebral hypovolemia secondary to vasovagal or dysautonomic manifestations. Other causes depends on risk factors in the patients, like patients with diabetes are subject for hypoglycemic comas, a patient with migraine, their auras sometimes resemble a seizure, sleep disorders, especially narcolepsy, where the persons may fall down to the ground after having a sudden event which could be fearful or none. It's called narcolepsy cataplexy syndrome. Some movement disorders also is paroxysmal, like whether kinesogenic associated with movement or non-kinesogenic, sometimes occur during sleep or sometimes during activity. Transient ischemic attacks also sometimes could be a few minutes. It occurs also in patients with risk factors of stroke. Psychogenic seizure is very important and is very common and sometimes very challenging for the diagnosis. And we differentiate between it and true seizure by a lot of factors. Some of them is, for example, eye open during the event is mostly organic. Eye closed during the event is mostly psychogenic. Physical injury is common with true seizure, not with psychogenic seizure. Psychogenic seizure usually occurs in front of audience, never during sleep, while true seizures usually associated with physical injuries. Psychogenic seizures usually not associated with such events. Other factors like malingering, sleep disorders like panic attacks, some kids disorders like intermittent explosive disorder, or the famous type breath holding spells when the children cry and hold their breath, then they become cyanotic, and once they have their breath again, they will experience stoppage of the event. This is not seizures. The second question, is it provoked or unprovoked? As we mentioned previously, that there is difference between the two. The acute provoked seizure or acute symptomatic seizure, the treatment would be treatment of the underlying etiology, while unprovoked seizures is usually epileptic in nature and treated by anti-seizure medications. Provoked seizure is not what we called seizure precipitant. Seizure precipitant could be an etiology or could be associated factors of any seizure, like metabolic and electrolyte imbalance, stimulants, drugs, hormonal changes, stress, fever, head injury. Uh, these are the different types of metabolic and electrolyte imbalance. The most common is hypoglycemia, hyperglycemia, hyponatremia, hypocalcemia, hypomagnesemia. Drug abuse, especially street medications, and some common medication that's used in different disorders and might cause seizures. Uh, Etiology of seizures according to their age of onset, whether seizure or epilepsy. In infancy and childhood, usually perinatal injury is the most common, while childhood and adolescence, genetic epilepsy is most common. Younger adults, heat trauma and drug intoxications are usually the most common, while in elderly, stroke, tumors, neurodegeneration, as well as metabolic disturbances. Afterward, we classify the seizure. Is it local or generalized? It's very important. Focal epilepsy is usually of adult onset, while generalized epilepsy is usually of childhood onset. The focal epilepsy is usually symptomatic rather than genetic. The focal epilepsy is usually associated with interictal pathology that's seen with neurological examination as well as imaging of the brain. On treatment, focal epilepsy usually resistant to medication. Nearly 40% only respond to anti-seizure drugs, while generalized epilepsy is usually more responsive. Injury is usually more with generalized epilepsy, where impairment of consciousness and fall to the ground is common, while focal epilepsy is not that common unless it progressed to generalized epilepsy, which is known as focal to bilateral. The next question is evidence of interictal CNS dysfunction. It helps me diagnose of epilepsy, especially after even with single unprovoked seizure. So we do have single unprovoked seizure, and on examination we do have interictal dysfunction. Diagnosis of epilepsy is given even with a single seizure. Syndromes, epilepsy syndromes. Epilepsy syndrome is a group of signs and symptoms occurring in high-risk patients groups. They have a particular age of onset, particular age of offset, sometimes even response to particular anti-seizure medication. We have a lot of epilepsy syndromes. Some of them are symptomatic, some of them are idiopathic, some of them are generalized, some of them are focal, some of them have age of onset in childhood, some of them have an age of onset during adulthood, some of them are responsive or benign, and some of them are malignant or with encephalopathies. As some examples for pediatric epilepsy syndromes, we have idiopathic generalized epilepsies, childhood absence epilepsy is very common and presented with non-scholastic, low scholastic achievement. The main seizure type is absence. Sometimes they have infrequent generalized motor tonic-clonic seizure. On the other hand, juvenile myoclonic epilepsy, where myoclonic seizure is the main seizure type, sometimes it is associated with absence epilepsy or later in life generalized tonic-clonic seizure. The childhood absence epilepsy has age of onset usually in the juvenile age, while the juvenile myoclonic epilepsy is a lifelong epilepsy syndrome. Benign epilepsy with centrotemporal spikes, another syndrome that happens in pediatrics, but this time it is focal, it arises from the temporal lobe, and it is benign, means it usually disappears by the age of 16 or 17, and it does not affect the patient quality of life. Excellent prognosis. Acquired syndromes, we do have infantile spasms, and we do have Lennox-Gastaut syndrome. These are just examples. The infantile spasms are flexion or extension spasms occurring in kids during their first year of life. It could be caused by multiple causes, whether genetic or developmental. Lennox-Gastaut syndrome sometimes is considered an expansion of the infantile spasms, mostly caused by perinatal causes. It has characteristic EEG known as hypsarrhythmia, and the seizure type is mixed, focal and generalized, and it carries bad prognosis. So, investigations. What are the investigation of patients with epilepsy? The most important one and on top of the list is history. History is the most important investigation of a patient having a seizure. Then we do examination, neurological and general examination. Then we look for exclusion of acute symptomatic seizure by doing blood tests, lumbar puncture, as well as brain imaging. And we do have electroencephalogram when the seizure is suspected to be epileptic, meaning non-provoked, and imaging of the brain itself to diagnose acute symptomatic seizure or symptomatic epilepsy. This is how the EEG machine looks like. We do have electrodes that are put it on the scalp of the patient in a 10-20 system to cover most of the brain cortex. The subject lie comfortably, close his eyes. We start recording, usually for 20 minutes. EEG helps us to know the type of epilepsy. We can diagnose epilepsy syndromes, but it is insensitive, meaning if I send 5 patients who do have epilepsy, only one person might have an abnormal EEG. These are the waves that is recorded on the EEG according to their number per second. If it is less than 4, it's called delta, 4 to 7 is theta, alpha between 8 and 12, and this is the most common for adults, or beta more than 12. Delta and theta mostly present in kids, while alpha mainly present in adults. When we comment on the EEG, we comment on the background to see if there is asymmetry between the right hemisphere and left hemisphere as regard the amplitude or the frequency of the waves. And we also look for interictal abnormalities. Interictal means abnormalities that is not present during the seizure event. And it is described according to its shape, the duration of the event. If it is very small duration, it's called spikes. If it is a little bit wider, it's sharp waves. If it is followed by a slow wave, it's called sharp or spike wave complexes. These interictal events could be focal in one area of the brain or could be in one hemisphere and not present on the other. It's called lateralized, or sometimes it is generalized in both cerebral hemispheres. As you see, the first row is sharp waves. Second one, where the ascending and descending lengths of the wave are almost on each other, is called spikes. When it is followed by the slow wave, it's called spike slow wave discharge. Or it could be polyspikes or polyspikes followed by slow wave discharge. This is a common pattern in myoclonic epilepsy. This graph shows you a focal interictal discharge. As you see, the red arrow. This is generalized discharge. As you see, the background is completely normal. Then suddenly, acute onset, acute offset, paroxysm of sharp slow wave discharge, or spike slow wave discharge, or polyspike slow wave discharge, usually seen with myoclonic epilepsy or idiopathic generalized epilepsy. This is the common pattern of benign epilepsy with centrotemporal spikes that we spoke about as a benign epilepsy syndrome affecting kids. This is a photic-induced seizure when the person is exposed for flickering lights. We can see the driving response here. This is myoclonic epilepsy where there is polyspike discharge. Brain imaging helps us diagnose epilepsy. If a patient have a single seizure and we do his MRI and found something like that old stroke where there is excavation of the right cerebral hemisphere, so we can diagnose the epilepsy after the first unprovoked seizure. Here is another patient who have seizure, and he has that cortical dysplasia, one of the congenital malformations that might be responsible for epilepsy, which is usually drug-resistant epilepsy. Thank you. In this section, we are going to speak about treatment of epilepsy. Anti-seizure drugs is the main or the cornerstone of treatment of epilepsy. if the patient did not respond to antiepileptic drugs, by definition called intractable epilepsy. This is justified when the person is put on antiepileptic drugs for a year, and the antiepileptic drugs is tried in the optimum dosage and optimum duration in a monotherapy trial as well as combination trial, and the patient is still reporting seizure. This is called intractable epilepsy. This group of patients are going to be exposed either for trial of new antiepileptic drugs or other ways, which is called non-pharmacological treatment, that can be gathered into neurostimulation, epilepsy surgery, or even diet regimen. Medical treatment or anti-seizure drugs. It is the mainstay, as we mentioned, and when we choose anti-seizure drug, we choose it according to multiple factors. All of them are very important. Why I choose this drug for this particular patient. Some of them are related to the epilepsy, some of them are related to the medication itself, some of them are related to the person himself. We can go through them. Seizure type. For example, focal or generalized. Drugs that work against focal seizure is different from those that work against generalized seizure. Epilepsy syndromes. Some of epilepsy syndromes are composed of single seizure type, and some of them are composed of multiple seizure types. As we mentioned before, that some epilepsy syndrome respond to particular anti-epileptic drug. For example, juvenile myoclonic epilepsy responds very well to valproate. It's a medication that works against these three seizure types, which are myoclonic, absence, and generalized tonic-clonic seizure. The efficacy of the drugs. Each drug has a known efficacy. All the medications or the first generation medications, which are valproate, carbamazepine, phenytoin, these are the old medications. Their efficacy is well known, while newer generations are compared to the old ones, and each one has a spectrum of efficacy. Some of them are effective against focal, and some of them are effective against generalized. Even within the generalized, some of them are against absence, and some of them are against motor tonic-clonic seizure. As we see here, these are the medications that has broad spectrum, means they work against multiple seizure types. And we do have narrow spectrum agents. Those might act against, for example, partial onset seizure like phenytoin, while isoxamide, for example, works only against absence seizure. The best drug for generalized onset tonic-clonic seizures, the best evidence that comes from randomized double-blind placebo-controlled trials, valproate and topiramate comes on top of the list. This list is always changing when new studies comes to the literature. For absence seizure, isoxamide, valproate, and lamotrigine. For myoclonic seizures, valproate, levetiracetam, clonazepam, zonisamide, all of them are effective against myoclonic seizures. We do have medications that might make seizure worse, like carbamazepine, phenytoin, phenobarb. They make absence seizure worse. Lamotrigine, they make myoclonic seizures worse. This situation could be met when we treat epilepsy syndrome, where the patient experience more than one seizure type. And you describe a medication like carbamazepine for tonic-clonic seizure, while the patient also have absence seizure, and then he will go into maybe status epilepticus because of absence seizures. Sometimes we choose a medication according to the patient comorbidities. Elderly, for example, or women might have osteoporosis, and anti-epileptic drugs, some of them are enzyme inducers, like phenytoin, phenobarb, carbamazepine, that might accentuate the osteoporosis. So they are not a good choice in these kind of patients. Some of patients might have migraine, And we do have anti-seizure drugs that works well against migraine as well as epilepsy, and choosing one of them will save a patient from another drug to be put on. Depression, we do have anti-seizure medications that might cause aggravation of the depression, like levetiracetam. So it's not a good choice in a patient having depression. On the contrary, we do have anti-seizure drugs that might make the mood of the patient better, like lamotrigine. Adverse events of the anti-epileptic drugs. We should talk with our patients about adverse events. Some of them are related to the dosage. That's why it is wise always to start with a small dosage and increase it in a stepwise. And some of them are not related to the dosage, but idiosyncratic effect. Examples for the dose-related adverse events: most of antiepileptic drugs, especially those working on sodium channels, cause ataxia or dizziness or diplopia, irritability and nervousness, especially in the juvenile age with levetiracetam, cognitive effects with topiramate, weight loss with topiramate zonisamide, weight gain with valproate, and sometimes carbamazepine. While the one that is like an allergy, for example, renal stones with topiramate, anhidrosis, topiramate, acute angle glaucoma, topiramate, hyponatremia, oxcarbazepine, and carbazepine. Sometimes it is very severe, like hepatic failure with valproate, aplastic anemia with felbamate, which is nearly withdrawn from the market, retinal field defect with vigabatrin, rash, which is very common with phenytoin, carbamazepine, and with the new medication, zonisamide. When we start anti-epileptic drugs, as we mentioned before, we need to discuss these adverse events with the patients. Some adverse effects might be palatable, like if you are talking with an obese patient, he might choose anti-epileptic drug that decreases body weight. And some people who are not eating very well, and sometimes they are very skinny, and they ask for a drug that might make them able to eat in an average way. So sometimes choosing the anti-epileptic drug according to its side effect might help. But we need to discuss all these side effects with the patients before we start the medication in order to be familiar with them, in order to be able to report them if they happen, because sometimes they are hazardous, as we mentioned before, and in this case, the medication has to be stopped. If the patient becomes seizure-free when we start the antiepileptic drugs, we keep him on the medication for at least 2 years, and 2 years here of seizure freedom. If the patient is able to achieve these 2 years of seizure freedom, the possibility of epilepsy remission is nearly 60%, and he could be a subject for withdrawal of antiepileptic drug. If the person wants more success of his epilepsy remission, he might prefer keeping the medication for 5 years. With 5 years seizure free with medication, the possibility of seizure freedom is more than 80%. And it becomes 100% if the persons report no seizures after stoppage of the anti-epileptic drugs. So for another 5 years. So 10 years of seizure freedom, 5 of them with treatment and 5 of them without treatment, and the patient developed no seizure. Now he can declare him as cured from epilepsy. Of course, the word cure is more than enough. It's usually called epilepsy remission. The possibility of recurrence in this situation is quite low. We do have favorable factors for persons going into remission, like when they are epilepsy control is achieved with one medication at a low dosage. Uh, there were no other trials of anti-seizure medication, normal neurological examination as well as repeated EEG. If he has genetic epilepsy, especially benign syndromes. There is also some factors that we insist for the patient to take care of. If they notice their seizures occur after a particular stimulant, they need to abandon this stimulant. And there is common seizure aggravators like stress or insufficient sleep. We always ask persons to have adequate night sleep, which differ from age to age. Most of adults needs like 7 to 8 hours. For kids, more like around 10 hours, and for elderly, nearly 7 or 6 hours. If the patient doesn't respond for anti-seizure drugs, as we said before, and he has intractable epilepsy, he might be tried on different other ways. It could be diet like ketogenic diet, the well-known ketogenic diet, where there is low carbohydrate but adequate protein and high fat. It has its particular side effects. It's mostly effective in young, especially kids. Surgery could be curative if we can identify a lesion that is responsible for the seizure event, like mesial temporal sclerosis, where the seizure focus usually is the hippocampus or the amygdala. And the common surgery here is temporal lobectomy or amygdalohippocampectomy. It might cause seizure freedom in nearly 60% and more responsive epilepsy type in another 20%. And sometimes surgery is done to decrease the seizure frequency. For example, partial resection of the epileptogenic region or callosotomy if the persons have recurrent drop attacks or multiple subpile transection to decrease the spread of seizure across the cerebral cortex. Neurostimulation, and it is either through the vagus nerve stimulation or the responsive neurostimulation where an implant is put inside the brain. In case of vagus nerve stimulation, we do have a stimulator, subcutaneous one, on the left side of the chest, put around the vagus nerve. Its stimulation will reduce the seizure in patients having intractable epilepsy. Status epilepticus. Status epilepticus is the emergency in patients with epilepsy. And for epilepsy patients, if the seizure duration, if the seizure does not remit spontaneously after 30 minutes, it's considered status epilepticus. Statisticians have noticed that seizures that remain for 10 minutes or even 5 minutes are going to continue for 30 minutes. That's why the definition now is when you have a patient having continuous seizure activity for 10 minutes, you need to refer him to the nearest hospital for treatment. Another situation, when you do have two convulsive seizures, in between them, the patient does not regain his consciousness. Both of these seizures are called status epilepticus or convulsive status epilepticus. There is another form of status epilepticus which is non-convulsive status epilepticus. Here, there is no motor events, only non-motor seizures, but in a continuous manner, more than 30 minutes as we described before. It could take the speech or psychic or cognitive functions. As we mentioned, it is medical emergency because of the hypoxia, the hyperthermia, the hypotension, or the acidosis that result from the continuous muscular activity, and stoppage of seizure is a priority. When the person comes to the ER, we start giving him oxygen and do the necessary investigation. We establish an IV line, take a blood sample to identify the underlying etiology, as well as toxicology screen, and we give the person glucose in order to help with the oxygen, alleviate the hypoglycemia as well as the hypoxia. Then we stop the seizure and we do it in time manner. The first medication is diazepam. In any form of it in the first 10 minutes. Usually it can stop the seizure in more than 95% of them. If it didn't stop, we start using phenytoin, or in its IV or IM format. If it didn't respond, we start to look for other medications that can be given by IM or IV, like valproate, phenobarbital, or we give extra dose of midazolam or phenytoin. If the patient does not respond, we start giving him general anesthesia. We finally end by the first aid for seizures. It's very important that we all know how to help a patient having a generalized motor tonic-clonic seizure, because it might happen in any place. It could be in the street, in a mosque, in a classroom, etc. If the patient have the seizure, it's very important to stay calm. Single person stay with the patient. It's very important to time the onset of seizure in order to be able to diagnose status epilepticus. Don't get panic. Protect the patient from injury. If he has any surrounding thing that could hurt him, you need to remove it. If you have a pillow or something to prevent the person from injuring his skull from the fall to the ground, or from the tonic-clonic seizure, so to decrease physical injury. It's very important to remember that don't put anything inside the person's mouth. Don't try to restrain the person. And when the seizure stops, try to put him on his side for the tongue to get down out of the mouth. If the seizure did not stop, as we mentioned before, call the ambulance. If the patient continues seizing for 5 minutes, or he developed 2 seizures, in between them he does not regain his consciousness. Thank you.